Welcome to the deep dive. Today, we're getting into a really substantial piece of work.
We are. It's the BMJ Books publication, ABC of Spinal Cord Injury, the fourth edition.
Right, and it's incredibly thorough. We're talking about expertise from a lot of contributors, many from the Duke of Cornwall Spinal Treatment Center.
Exactly. So our mission here really is to pull out the key insights for you. We'll trace the whole journey, from the accident scene through rehab and into, well, long-term life with the injury.
Talking at everything, the immediate medical stuff, the therapy, the social aspects too. It's all in there.
It really is comprehensive.
Yeah, what I found striking is just how holistic it is. It's not just that initial trauma, but the whole long road ahead.
And the range of voices tells you just how complex this field is.
Definitely. Now, here's something that caught my eye early on. Some stats from the Duke of Cornwall Spinal Treatment Center. This was back in 1997 to 99.
Okay, what did they find?
Well, they broke down injuries by location. Cervical, so neck injuries, were 40%. Thoracic, the mid-back, was actually a bit higher at 45%. And lumbar, lower back, was 15%.
Huh. Thoracic slightly higher than cervical in that group? That's interesting.
Yeah, it makes you wonder about the specific types of accidents, maybe, that were leading to those admissions back then.
It does. It highlights how vulnerable the whole spine is, but yeah, subtle differences in patterns are always worth thinking about.
Okay, so let's start where the book starts right at the beginning.
Yeah.
At the scene of the accident, someone's just had a potential spinal cord injury. What are the absolute top priorities?
Number one, without a doubt, is preventing secondary injury. You have to stop any further damage to the cord.
And how do you do that?
Mainly by keeping the spine perfectly aligned. Any movement, bending, twisting, it could make things much, much worse.
So imagine you're there first, no fancy equipment yet. What's the immediate action?
Manual immobilization. Someone has to physically hold the head and neck steady, stopping any movement until you can get proper collars or splints on. That's critical.
Okay, holding steady and then moving the person. That sounds incredibly risky.
It is. It has to be done very carefully. The book mentions two main ways. The ideal is the four-person log roll.
For people.
Yeah. One person is just focused on the head and neck alignment, directing everything. The others support the shoulders, hips, legs. Everyone moves together, keeping the spine straight, while a spinal board is slipped underneath.
Right, keeping it like a log, basically.
Exactly. The other option is a scoop stretcher. It sort of clamps around the person, then you lift them onto the board. Again, the goal is minimal spinal movement.
Minimal movement, got it.
Mhm.
Now, the book flags some specific breathing concerns, especially for tetraplegics, right there at the scene.
Yes, this is really important. For tetraplegic patients, you generally want to avoid suctioning the airway if you possibly can at the scene.
Why that?
It can trigger something called the vagal reflex. This can slow the heart rate down, which might already be low, and in, rare cases, it could even lead to cardiac arrest.
Wow. Okay, so if suctioning is absolutely essential.
Then medical professionals should ideally pre-treat with atropine and give oxygen first to sort of counteract that potential vagal effect.
Mm.
Later in hospital, they'd use things like flexible fiber optic scopes for intubation if needed, especially with neck fractures.
Okay, that vagal reflex is a crucial detail. What about getting an IV line started? Standard procedure, but any catches with spinal injuries?
Well, yes, IV access is important. Associated injuries are common, but, and this is a big but with high spinal cord injuries cervical, upper thoracic, the sympathetic nervous system, is disrupted.
Right.
This can cause neurogenic shock, low blood pressure, sometimes a slow heart rate. So you have to be really careful not to overload them with IV fluids. Too much fluid could lead to pulmonary edema, fluid in the lungs.
So it's a balancing act. Support, but don't overdo it.
Precisely.
What about the actual splints and collars used at the scene?
You typically use short and long back splints together, plus a properly fitted semi-rigid cervical collar. That whole setup helps keep the upper spine stable.
And if you don't have those right away?
Then it's back to that crucial manual immobilization we talked about. Keep holding steady. For little kids, the book mentions securing them in their child seat, using padding for head support, maybe forehead straps too.
Good point about kids needing different approaches. Now, temperature regulation. That wasn't something I'd immediately connect to a spinal injury.
It's a major factor, especially with higher injuries like tetraplegia or high paraplegia. The body's ability to regulate its own temperature gets impaired because the sympathetic nervous system isn't working properly below the injury.
So they can't shiver or sweat effectively?
Exactly. They become sort of poikilothermic. Their body temperature drifts towards the temperature of the environment. Hypothermia, getting dangerously cold, is a real risk, especially outside.
So keeping them warm is vital.
Absolutely. Blankets, thermoreflectors, especially during transport.
And speaking of transport, the book mentions helicopter transfers.
Yeah, for remote locations or long distances, helicopters can really improve outcomes, both survival and reducing long-term disability. They allow direct, fast transfer to a specialized spinal injuries unit.
Which is the ideal destination.
Definitely. Ideally, you coordinate with the unit beforehand.
Okay, so the patient makes it to the hospital, arrives in the emergency department. What's the drill there?
Right, so the primary survey starts immediately. Ideally, you're getting the medical history while they're being transferred onto a trauma trolley. If they came in on a spinal board, that's great. You can use that to transfer them smoothly. A scoop stretcher works too, maybe just takes a bit longer.
And then it's the standard trauma assessment.
Yep, the ATLS sequence kicks in. Airway, making sure it's clear while keeping the neck immobilized. Breathing check, circulation check, central nervous system assessment, a quick neuro check, and then exposure, removing clothes to check for any other injuries.
And you have to remember the spinal injury itself can mess with A, B, and C.
Absolutely. Airway, breathing, circulation can all be directly affected by the level of the injury.
And the book stresses that these injuries often don't happen alone.
That's a critical point. The data they cite shows lots of associated injuries. Head injuries in about 12%, chest in 19%, limbs in 20%, even abdominal injuries needing surgery in about 3%.
So you have to look everywhere, not just the spine.
You really do. A full trauma workup is essential.
Then comes the specific neurological assessment. They use a standard scale for that, right?
Yes, the A-Shaw impairment scale. You might still hear the older term, Frankel grades. It goes from A to E.
A being the most severe.
Correct. Grade A is a complete injury, no motor or sensory function below the injury level. Grade E means basically full neurological recovery.
And how do they determine the grade?
It involves detailed testing, checking sensation, light touch, and pinprick at specific key points on the body, and testing muscle strength in specific muscle groups, called myotomes, to find the motor level. It's not just a label. It helps predict recovery potential and guides rehab.
I see. And there's specific reflexes they check, too.
Exactly. The anal reflex and the bulbocavernosus reflex are really important. They test the integrity of the sacral reflex arcs right at the bottom of the spinal cord.
How do they test those?
Well, the anal reflex is a quick squeeze of the sphincter muscle when you lightly prick the skin nearby. The bulbocavernosus involves checking for that same sphincter contraction, usually with a gloved finger, when you squeeze the glans, penis, or clitoris.
And what do these reflexes tell you?
Their presence or absence, and when they return after the injury, helps distinguish between an upper motor neuron lesion, where the reflexes might come back after a few days, and a lower motor neuron lesion, where they usually stay absent. Injuries to the very end of the cord, the commissus medullaris, or the nerve roots below it, the cauda equina, are lower motor neuron types.
Right, and the book specifically mentions cauda equina syndrome.
Yes, that's damage to those nerve roots in the lower spinal canal. A key sign is a flexial loss of reflexes in the bladder, bowel, and legs.
Okay, so clinical assessment done. Now you need to actually see the damage. Radiology time.
Precisely. Imaging is crucial to figure out the exact level and type of bony injury.
And typically starting with x-rays, especially for the neck.
Yes, lateral cervical x-rays are usually the first step. You're looking for things like displacement. If one vertebra has slipped more than 3.5 millimeters relative to the one below it, that's abnormal.
Forward or backward slip.
Either. And the amount of forward slip can suggest the type of facet joint dislocation. Less than half the width of the vertebra below, probably unilateral. More than half. Likely bilateral, which is much less stable.
What else are they looking for on that side view?
Another key thing is the gap between the front of the C1 vertebra, the atlas, and the odontoid process of C2, the axis. If that gap, the atlantoaxial interval, is too wide, more than 3 millimeters in adults, 5 millimeters in kids, it suggests instability there.
And specific fracture types can signal instability too.
Definitely. A teardrop fracture, a fragment off the front bottom corner of the vertebral body, often means an unstable flexion injury. An avulsion fracture off the front top corner might mean a severe extension injury.
So x-rays give clues about mechanism and stability. What about the front to back view, the AP view?
On the AP view, you look at the spinous processes, those bumps down the back. If one is shifted off the midline, it suggests the vertebra has rotated. You often see this with unilateral facet dislocations. The spinous process points towards the dislocated side.
Okay. What about imaging the thoracic or lumbar spine? More challenging.
It can be, yeah. Stuff gets in the way on x-rays. But standard AP and lateral views are still important. The lateral view, especially a horizontal beam one, is good for seeing burst fractures, where the vertebral body crushes, and checking if the back parts, like facet joints or pedicles, are involved.
And instability there is defined how?
Generally, if at least two of the three columns of the spine are disrupted, it's considered unstable. A simple wedge fracture just involving the front column is usually stable.
The book mentions CT scans being useful sometimes.
Yes, especially for tricky areas like the upper thoracic spine, which is hard to see well on X-ray, or for really complex fractures. CT gives much better bony detail.
And MRI, that shows different things, right?
Absolutely. MRI is fantastic for looking directly at the spinal cord itself and the soft tissues, ligaments, discs. It can show if the cord is transected, swollen, bruised, or if there's a herniated disc pressing on it, stuff you just can't see on X-ray or CT.
Gotcha. The book also mentions chance fractures. What are they?
Ah, yes, those are specific horizontal fractures, usually in the upper lumbar area. They often happen from extreme flexion, like with a lap seatbelt and a bad crash.
Seatbelt injury.
Can be, yeah. And the really important thing with chance fractures is that they're often linked to internal abdominal injury, so you have to have a high suspicion for those two.
Right. The spine injury can be a sign of water trauma.
Right.
Okay, so diagnosis is clear. Now, immediate medical management. Respiratory and cardiovascular issues seem top of the list early on.
They absolutely are. Respiratory problems are a huge concern, particularly with tetraplegia.
Why is that?
Paralysis of the intercostal muscles, the ones between the ribs, makes breathing less efficient. Sometimes the diaphragm is affected too if the phrenic nerve is involved. Plus, they can't cough effectively to clear secretions.
So, risk of pneumonia and lung collapse.
Big time. Even with paraplegia, intercostal function can be reduced, and associated chest injuries like broken ribs make it worse.
So, what are the key interventions for breathing?
Regular chest physiotherapy is vital. Things like assisted coughing, positioning, breathing exercises. You need to monitor them really closely. Oxygen saturation, vital capacity, how much air they can breathe out, and blood gases.
Is there a critical point where you know they need ventilation support?
Yeah, the book mentions a vital capacity dropping below about 15 milliliters per kilogram, especially if their CO2 level is rising in the blood. That signals they likely need help breathing.
We kind of
Often non-invasive support first, like BiPAP, which provides pressure support during breathing that can sometimes avoid needing intubation. Any air they breathe needs to be humidified too to keep secretions loose.
And if they do need ventilation, is there a specific way to wean them off later?
Ideally, weaning is done with the patient lying flat, recumbent. That position lets the diaphragm work most effectively.
Okay. Moving to the cardiovascular system. Bleeding from other injuries is a common cause of shock, but the spinal injury itself can cause problems.
Yes, neurogenic shock. In tetraplegia especially, the loss of sympathetic nerve signals below the injury means the vagus nerve is unopposed. This can lead to low blood pressure and a slow heart rate.
Bradycardia again.
Right. Even in paraplegia, losing sympathetic tone below the lesion can drop blood pressure. The key thing is distinguishing this from shock due to bleeding.
Because the treatment is different.
Very different. Giving large amounts of 5V fluid for neurogenic shock, thinking it's blood loss, can easily cause fluid overload and pulmonary edema.
That's a crucial distinction. Are there any medications to be extra careful with in this early phase?
Yes, a big one is suxamethonium, a muscle relaxant sometimes used for intubation. Between about 3 days and 9 months after a spinal cord injury, using it can cause a massive, potentially fatal release of potassium from muscles hyperkalemia.
So it's contraindicated.
Absolutely during that window. If you need muscle relaxation, you use a non-depolarizing agent instead, like rocuronium.
Good to know.
Yeah.
What about blood clots? DVTs, PEs?
Huge risk, especially in the first few weeks. Pulmonary embolism is a major cause of death after the initial injury, peaking around week 3.
So prevention is key.
Essential. Anti-embolism stockings for everyone unless there's a reason not to. And starting anticoagulants, usually low molecular weight heparin, within 72 hours, again, if there are no contraindications like active bleeding.
And with all these potential issues, ongoing checks are vital.
Constant vigilance. Reassessing frequently, especially in that first month, to catch any missed injuries or developing complications.
Okay, let's talk about managing the spinal injury itself.
Yeah.
Stabilization is obviously paramount. For neck injuries, the book talks a lot about skeletal traction.
Yes, that's often the initial step for cervical spine injuries. Using skull calipers to apply traction.
What's the goal of that?
To realign fractures or dislocations, take pressure off the spinal cord, and provide stability while things start to heal or before surgery.
What are these calipers? How do they attach?
There are a few types. Gardner Wells are common, spring-loaded ones. They're applied to the skull just above the ears after numbing the area. The pins grip the outer layer of bone. Cone calipers need small incisions. The old Crutchfield type isn't really recommended anymore due to risks.
And how much weight do they use? How is the patient positioned?
It depends. For a stable fracture without dislocation, maybe 3 to 5 kilograms. Importantly, you use a neck roll, not a sandbag, to support the natural curve, the lordosis, and you have to watch for pressure sores on the back of the head.
What if there is a dislocation?
Then you often need to gradually increase the weight to reduce it, maybe adding 4 kilograms every half hour, up to maybe 25 kilograms. The neck might be slightly flexed initially to help unlock the joints, then extended once it's reduced and the weight is lowered for maintenance.
Sounds like a delicate process.
Extremely. You have to check their neurological function constantly during reduction. If anything gets worse, you reduce the weight immediately.
The book mentions halo traction as another option.
Yes, a halo ring attached to the skull with pins connected by bars to a vest. It's particularly useful for incomplete injuries, as it allows for much earlier mobilization, getting the patient up and moving in the halo brace.
And surgery. When does that come into play early on for neck injuries?
Early surgical fusion might be done for incomplete injuries to prevent further neurological damage by definitively stabilizing the spine. Sometimes this decision is made even before transfer to the specialist unit, but always in consultation with them.
Which brings us back to getting patients to those specialized spinal injuries units.
It's absolutely critical. The evidence shows that early transfer leads to better outcomes. Lower mortality, more neurological recovery, shorter stays, even lower overall costs. As soon as SCI is suspected, the nearest unit should be contacted.
Okay, so the patient is now in the specialist unit. The focus shifts to managing ongoing issues and common complications. Autonomic dysreflexia seems like a big one.
It is a potentially dangerous complication, mainly in injuries above T6, so mid-thoracic level and higher. It can happen any time after spinal shock wears off.
What triggers it?
Most commonly, something happening below the level of injury that the body interprets as noxious. A blocked urinary catheter causing bladder distension is the classic trigger. But it could also be a full bowel, a UTI, skin breakdown, even things like ejaculation or labor.
And what actually happens in the body?
That trigger sets off a massive sympathetic reflex below the injury level. Blood vessels clamp down, causing blood pressure to shoot up. The brain detects this high BP and tries to slow the heart rate via the vagus nerve, but the signal to dilate blood vessels below the injury gets blocked.
So you get this weird combination.
Exactly. Pounding headache, sweating and flushing above the level of injury, but potentially pale and cool skin below, and a slow heart rate despite dangerously high blood pressure. It can cause stroke if not treated quickly.
So, first step in treatment.
Find and fix the trigger. Unblock the catheter, empty the bowel, whatever it is. Sitting the patient up helps lower BP too.
If that doesn't work.
Medications might be needed, things like nifedipine or a GTN spray under the tongue, maybe intravenous phentolamine. For recurrent problems, sometimes more invasive options are considered, but fixing the trigger is always number one.
The book also covers biochemical issues, like sodium and calcium levels going awry.
Yeah, hyponatremia low sodium can happen for various reasons. Too much 5e fluid initially, or later on from infections, certain drugs, or drinking excessive water, or SIADH. Treatment depends on the cause, maybe fluid restriction, treating infection, changing meds. You have to correct it slowly, though.
And high calcium.
Hypercalcemia.
That's usually due to bone resorption from being immobile, more common in tetraplegia. Symptoms can be vague constipation, tummy pain, headache. Treatment involves hydration, maybe diuretics, and drugs like bisphosphonates to lower calcium. It usually settles once they're more mobile.
Okay. Another very common issue is spasticity. Yes, increased muscle tone, exaggerated reflexes. It only happens in upper motor neuron lesions after spinal shock resolves. It often gets worse over weeks and can be more severe in incomplete injuries.
Is it always bad?
Not necessarily. While severe spasticity can interfere with function and cause pain or contractures, mild spasticity might help maintain muscle bulk, support circulation, even assist with some transfers.
So you don't always try to eliminate it.
Right. Treatment focuses on when it's problematic. First step is always to look for and treat triggers like pressure sores, UTIs, ingrown toenails, anything irritating.
What else helps?
Stretching, regular standing if possible. Then there are oral medications like baclofen, tizanidine, dantrolene. For localized spasms, botulinum toxin injections can work well.
And if oral meds aren't enough?
Intrathecal baclofen delivered via an implanted pump directly into the spinal fluid can be very effective for severe, widespread spasticity. Older, more destructive procedures are rarely done now because they can affect bladder and bowel function.
And we can't talk complications without mentioning pressure sores.
A constant risk due to immobility and lack of sensation. Prevention is everything.
How do you prevent them?
Regular pressure relief, turning in bed every couple of hours, shifting weight in the wheelchair every 15 minutes, using the right mattress and cushion, often assessed with pressure mapping, avoiding shear forces during transfers, daily skin checks. Patient education is vital. Pressure clinics are key for ongoing management.
Moving on to urological management. Clearly a massive area.
Hugely important for long-term health and quality of life. Initial management is about preventing bladder overdistension and infection, usually with an indwelling catheter initially. Strict hygiene is crucial.
What kind of catheter?
Small, pure silicone ones are often preferred, changed maybe every 6-8 weeks. Using catheter valves to allow the bladder to fill and empty periodically, cycling can help maintain its capacity and elasticity. Sometimes anticholinergic meds are needed if the bladder muscle is overactive.
But long-term catheters have downsides.
They do. Risk of urethral damage, infections, stones, upper tract problems like kidney damage from back pressure, and they can trigger autonomic dysreflexia.
So finding the right long-term strategy is important and personal.
Very personal. It's about balancing continence, freedom from catheters, and kidney safety. The individual's lifestyle and abilities are key factors.
What are the main alternatives to long-term indwelling catheters?
Intermittent self-catheterization, or ISC, is often the preferred method if feasible. The person drains their bladder with a catheter several times a day. It reduces many complications.
But not everyone can do ISC.
Right. It can be difficult for women with paraplegia or people with tetraplegia who lack hand function. For them, surgical options like creating a catheterizable stoma, maybe using the appendix like in a Mitrofanoff procedure, can be life-changing.
And more advanced options. Neuromodulation.
Yes. Sacral anterior root stimulation, or SARS. Implanted electrodes stimulate the nerves for bladder emptying. It works best for complete injuries above the sacral level. It often involves cutting some sensory nerve roots, rhizotomy, to stop reflex incontinence, and helps prevent dysreflexia. It can also help with bowel function and erections.
What about the tricky situation where the bladder muscle is overactive, but the sphincter muscle doesn't relax properly?
The Trusser sphincter dysynergia, or DSD. That's risky because it creates high pressure in the bladder, potentially damaging kidneys and triggering dysreflexia. Treatment involves managing the overactivity with meds or Botox, sometimes surgery on the sphincter or bladder itself, or neuromodulation.
Let's switch gears to nursing care. These patients need a huge amount of support.
Absolutely. Hospital stays are long, often months, and while it used to be mostly young men, more older people are experiencing these injuries now. The psychological impact is immense: fear, anxiety, sensory issues, grief. It affects the whole family.
And certain milestones are particularly tough.
Yes, things like the first time getting into a wheelchair, the first home visit, discharge itself. They're huge emotional hurdles.
What's the nursing role right back in the emergency department?
Maintaining that spinal alignment on the board, applying collars, maybe using sandbags. Crucially, ensuring the collar isn't removed until a doctor clears the spine after assessment and x-rays.
And in the unit.
Yeah.
Bed choice. Positioning.
A good supportive mattress on a standard bed often works, especially for traction. Special powered turning beds might be used for very heavy patients or those with multiple injuries. Turning requires specific techniques like the log roll needing several staff, or the pelvic twist for some tetraplegics, but not for lower spine injuries. Careful head and neck control is always paramount.
And nurses manage the patient's internal environment too.
Yes, respiratory care, assisted coughing, suctioning if needed, hygiene. Cardiovascular monitoring for that potential low blood pressure and heart rate in high lesions. Applying anti-embolism stockings. Temperature control, watching for hypothermia. Addressing sensory deprivation, helping orient the patient, providing stimulation without overwhelming them.
Basic hygiene and nutrition must be vital too.
Totally. Keeping skin clean, managing minor infections, careful nail care, educating patients about risks from sensory loss. Nutrition is key because they're at risk of malnutrition from the trauma, potential gut issues, or just difficulty feeding themselves. Nurses assess needs and assist with feeding or manage tube feeding if required.
And bladder and bowel management is a core nursing function.
Definitely. In the acute phase, monitoring fluids, preventing bladder overdistension, strict hygiene with catheters. Long term, it's about supporting the chosen management method, preventing complications, and empowering the patient. Bowel care starts with preventing impaction during spinal shock, then establishing a regular routine using techniques like suppositories, digital stimulation, or manual evacuation, ideally timed for privacy and convenience.
The book even mentions sexuality as part of nursing care.
As it should be. Creating a space to discuss concerns, providing accurate information, dispelling myths, exploring intimacy options. It's part of holistic care. Other things include passive range of motion exercises for paralyzed limbs daily, but carefully done. And managing the gradual process of getting into a wheelchair, watching for postural hypotension, and teaching those crucial pressure relief techniques.
Physiotherapy then comes in, focusing on maximizing function.
Right. Physio aims to help patients regain as much movement and independence as possible. Relearning balance, strengthening working muscles, mastering transfers bed to chair, chair to toilet, and becoming proficient with wheelchair skills.
What about standing? Does that help?
Regular standing using frames or tilt tables can have benefits, potentially reducing spasticity, maintaining bone density, preventing contractures. But it has to be done gradually, especially if they have postural hypotension, maybe using abdominal binders.
Is walking ever a goal?
For some, yes. Usually those with lower thoracic or lumbar injuries. It typically requires calipers, crutches, and a lot of energy. Different orthotic devices like RGOs can help some people, but they need specialist fitting and training. It's not suitable for everyone.
And recreation.
Sports.
Very important. Wheelchair sports, swimming, archery, they help with strength, balance, fitness, and crucially, social reintegration and confidence.
Are incomplete injuries different for physios? Yes, often more complex. There's such a wide variation in what function remains. Spasticity or sensory loss can limit function even if muscle power seems okay. Treatment has to be really individualized, and recovery can take much longer, often needing ongoing community physio.
And physio for children with SCI.
The focus there is often on preventing secondary problems like scoliosis, encouraging bone growth through weight bearing with braces or calipers, supporting walking if possible, but also ensuring they have appropriate wheelchairs for school and social life. They need ongoing follow-up as they grow.
Okay, let's bring in occupational therapy. Where do they fit in?
OTs focus on helping patients adapt and manage daily life tasks despite their limitations. Personal care, domestic chores, communication, finding alternative ways, or using adaptive equipment. They're also heavily involved in advising on home modifications, wheelchair selection, driving options, return to work or study, and leisure.
Hand function and tetraplegia must be a key area for OTs.
Absolutely. They assess hand function and work on optimal positioning. For someone with a C6 injury, strengthening wrist extensors to achieve a tenodesis grip, where wrist extension passively closes the fingers, can be really valuable. They might provide splints for writing, eating, typing, or pushing a wheelchair. Sometimes they're involved in assessing suitability for hand surgery.
And they're involved in discharge planning, too.
Critically, that pre-discharge home visit usually involves the OT, social worker, family, maybe community services. It's about making sure the home environment is safe and accessible and planning the support needed. Trial weekends at home are often arranged based on OT assessments too, their vital practice runs.
And the actual retraining of daily activities.
OTs work on all those activities of daily living, or ADLs. Eating, drinking, washing, dressing, moving in bed, transfers, making tea, using appliances. They teach adapted techniques and provide tools or splints to make tasks possible. For communication, especially for high tetraplegics, they might introduce writing splints, mouth sticks, electronic aids, or environmental controls.
The level of independence really varies by injury level, doesn't it?
Hugely. From needing full assistance for almost everything with a very high injury, to potentially being independent in personal care and driving with a lower injury, OTs help bridge that gap with strategies and technology.
Which leads us to the social needs. The impact goes far beyond the physical.
Immensely. The goal is enabling a fulfilling life, but that's defined by the individual. Most people want to live at home, but need support. Legislation and funding schemes like direct payments exist to help, but navigating the system and affording care can be major challenges.
Relationships change too, don't they?
Profoundly. Roles shift. Family members might become caregivers, providing very personal care. It's crucial that carers' own needs are assessed and supported too. Finances are almost always affected. Reduced income, increased costs. Getting the right advice on benefits is essential.
And housing. Getting services coordinated.
Adapting a home for wheelchair access is often necessary and expensive, even with grants. Finding suitable housing long-term can be difficult. Pulling together all the different statutory and voluntary services needed is a huge task. Information and empowerment for the patient and family are key. Employment and education are also major areas impacted.
So transferring care from that supportive hospital environment back to the community is a really big step.
It's a massive transition. The level of care needed varies wildly. Education is paramount, teaching the patient, family, and community carers about skin care, bladder and bowel routines, recognizing complications like autonomic dysreflexia. They need to become experts in their own care.
Skincare education involves what, specifically?
Things like how to do daily skin checks using mirrors, understanding the stages of pressure sores, knowing how to check their wheelchair cushion is still effective, often done in pressure clinics, choosing appropriate clothing, using the right mattress.
And bladder and bowel care continuation.
Making sure they can manage their chosen blast method, recognize signs of UTI or blocked catheters, maintaining the established bowel routine, knowing how to adjust it for lifestyle changes, avoiding overuse of laxatives.
Sounds like planning for discharge needs to start very early.
Ideally, yes. Addressing the big questions: where will they live, what care package is needed, who will provide it. Sometimes temporary solutions like intermediate care are needed first. Those first few weeks home are incredibly demanding physically and emotionally. Follow-up from community liaison specialists is really important.
Okay, let's look at some later complications that can arise years down the line. Spinal deformity, pathological fractures.
Spinal deformities like scoliosis or kyphosis can develop over time. Factors include the original injury, age, muscle imbalance, maybe inadequate early stabilization. Deformity can cause pain, pressure sores, breathing problems. Management involves seating adjustments, bracing, sometimes surgery. Pathological fractures happen because the bones in paralyzed limbs become osteoporotic, weak. A minor fall or even a strong spasm can cause a fracture, often around the knee or hip.
How are those fractures treated?
Usually conservatively, without surgery. Well-padded splints or casts, but they need careful monitoring for skin issues under the cast. You want to avoid immobilizing joints for too long to prevent stiffness.
Pain is another major long-term issue, isn't it?
Very common and complex. It can be musculoskeletal pain from overuse or posture, visceral pain from internal organs, or neuropathic pain arising directly from the damaged nerves. This can be felt at, above or below the injury level. Sometimes a fluid-filled cavity, a syrinx, can develop in the cord years later, causing new pain or weakness. Effective acute pain management might help reduce the risk of chronic pain developing.
And sexual function, that's significantly impacted.
Yes, in various ways. For men, reflex erections originating from the lower spinal cord are often possible with upper motor neuron injuries, but might not be sustained. Psychogenic erections, triggered by thoughts or sights, rely on pathways often disrupted by higher injuries. Emission and ejaculation involve different nerve pathways, too. Complete lower motor neuron injuries often prevent reflex erections.
Are there treatments or aids?
Yes, thankfully. Oral medications like sildenafil, injections into the penis, vacuum devices, penile implants. Sacral interior root stimulators can also induce erections. For ejaculation, vibrators or electroejaculation techniques can be used, though there's a risk of autonomic dysreflexia with ejaculation if the injury is above T6.
What about fertility for men?
It's often reduced lower sperm count and motility. But assisted conception techniques like IVF or ICSI have dramatically improved the chances of fatherhood. Treating any underlying infections is important, too.
And for women, pregnancy and childbirth.
Women with SCI can conceive and carry pregnancies. Labor might be painless if the injury is complete above T10. There's an increased chance of needing an assisted delivery. The main risk during labor for those with injuries T6 or above is autonomic dysreflexia, which is usually managed effectively with epidural anesthesia.
What about people with very high tetraplegia needing ventilators long term?
Injuries above C4 affect the diaphragm, requiring chronic ventilation. This might be via a mechanical ventilator or sometimes electrophrenic respiration, pacing the phrenic nerve to make the diaphragm contract. Phrenic pacing can allow more mobility, but isn't suitable for everyone and requires ongoing specialist support. These individuals need 24-hour care, which has huge implications.
Psychological factors must remain important throughout life.
Absolutely. Anxiety, depression, PTSD can emerge or persist long after the injury. Cognitive issues can sometimes occur too. Recognizing these and providing ongoing support for the individual and their family is crucial. Technological aids like functional electrical stimulation, FES, for hand grip or foot drop, or the bladder and bowel stimulators we mentioned, continue to evolve and offer functional improvements for some.
And neurological recovery, does it stop after a certain point?
Significant recovery is less likely after a complete injury, especially after the first year or so. But with incomplete injuries, recovery can continue, sometimes slowly, for 2 years or even longer.
Finally, the book touches on life expectancy and the situation in the developing world.
Life expectancy is unfortunately still reduced compared to the general population, though it has improved. It varies significantly depending on the level and completeness of injury and age at injury. The Aisha-Frankel grade is a predictor.
And the situation globally.
It's starkly different in many parts of the world. Higher injury rates, often affecting young men, mostly resulting in paraplegia. The challenges are immense. Lack of funding, trained staff, social support, accessible housing, basic equipment. Rehabilitation often takes a backseat to other pressing health issues like infections or maternal health.
What are the strategies suggested for resource-limited settings?
Focusing on prevention is key. Public education on safe handling and transport after accidents. Developing designated referral centers, even if basic. Training existing staff. Using appropriate low-cost technology for wheelchairs and orthotics. Crucially, involving families and carers. Providing psychosocial support. And empowering disabled people themselves to advocate and participate in society.
Wow. We've covered a huge amount of ground, really tracing the entire arc described in the book, from that initial moment of injury right through to lifelong management.
It really highlights the complexity, doesn't it? And the absolute necessity of that multidisciplinary team approach throughout. The challenges are just enormous.
Yeah, and thinking about it globally really brings those disparities in resources and care into sharp focus. It's also, I suppose, a testament to the innovation that can happen even when resources are scarce.
That's a really interesting point. Necessity being the mother of invention sometimes.
Definitely something to mull over. If you, the listener, want to learn more, there are great organizations out there, the Spinal Injuries Association, the International Medical Society of Paraplegia, doing vital work in research, support, and advocacy.
Absolutely. Continued efforts in all those areas are so important.
Because ultimately, while this deep dive shows the immense medical and social challenges, it also underlines the incredible resilience of people living with spinal cord injuries and the ongoing need for progress in care, rehabilitation, and importantly, social inclusion.